So I'm Steve Pergam. I'm the Director of Infectious Disease, Director of the Infection Control Program at the SCCA and a member of the Infectious Disease Division. All right, so every year, 2 million Americans will become infected with bacteria that are resistant to antibiotics, and at least 23,000 will die as a result, a direct result of these infections. And that's from the CDC's antimicrobial resistance specific page. It's humbling. It's incredibly important for all of us to be aware of this. In the antimicrobial resistance review that was sponsored through the UK government and the Wellcome Trust, what they looked at is they looked at predicting what would happen in the future with antibiotic resistance. And AMR is what this is the abbreviation for this. In 2050, they estimate that 10 million people will die of antimicrobial resistant infections. That's more than cancer, more than diabetes, etc. So we are concerned in the direction that these things are going, and part of the reason we're having these discussions is how we can affect change in a positive way. So I think there's a lot of questions about who's to blame. Where do we point the finger? Who's at risk and who is the reason that these things happened? And I think we have to be careful about this because frankly, and I think many of the speakers who will be on the panel and Maryn will discuss, many of us are really the problem, and it's really humans in general. It's how we use antibiotics in multiple different aspects of our life. So in medicine, we use antibiotics indiscriminately, and we are still learning how to do this correctly. Estimates are that 1/3 of patients who get antibiotics get them appropriately. There are places in the world where antibiotics are freely available. You do not need a prescription, where drug resistance is becoming rampant. Data in terms of resistance in Africa is very difficult to know, but there are major concerns that other parts of the world are going to be showing up at our door anytime. We're a mere flight away from India, where there's MDR1 and KPCs, which are major resistance pathogens, and so resistance is right around the corner from all of us. And then, of course, in agriculture, there's a significant amount of antibiotics used. About 80% of antibiotics used in the United States right now are used in agriculture. How much of this is really needed, how much of this is used for growth, et cetera, and where can we cut back in these specific areas, as I think is going to be an area of major interest for a lot of us. And I think Maryn will be introducing you to some of this history behind this and telling you some really, I think, impressive stories about what can happen if we don't do this well. But I think there's also important thing to take away is it's not just both of these, but it's also what these two things do to the environment and how what happens in these two industries, both from the standpoint of what we use as physicians and as patients, and from agriculture, how this affects major change in the environment. And I think Peter Rabinowitz, who'll be speaking a lot about One Health and this idea of bringing all this together and how we all need to work on this in different ways. I think it's important to remember why we're here. I work at a cancer center. I see cancer patients. This is a piece by Robert Pope, who is a Nova Scotia artist who died of Hodgkin's lymphoma before there were curative therapies. And we have an amazing array of new treatments and options that are available to patients. But antimicrobial resistance is one of the ways that we will lose those options. It is critical for immunocompromised patients to be protected from infections, and if we don't do this well, a lot of the major successes we've had will be lost. And the way I like to think about this is antibiotic resistance has the potential to not only change how we give cancer therapy, meaning that some patients may never be able to receive it, but also to derail many of the tremendous gains we've made. And so I think this is critical at a cancer center to be talking about antibiotic resistance. And I would really like to call out my two leaders of our division, Julie McElrath and Michael Book, for allowing this to happen, and to Gary Gilliland at the Fred Hutch Cancer Research Center, realizing how important this issue is and having this symposium here. I think it is a testament to what the Fred Hutch is all about. So, Maryn, I love this picture. I wish I could have taken this. I've recently got a new camera. This is, I think, from the Atlanta Constitution, an article that was done. It's brilliant. It shows her. She's tough, and she's really dogged in her work. She's an independent journalist and an author who specializes in public health and on local and global scale. She's really comfortable in a lot of ways talking about even bird flu on an Iowa farm versus MERS-CoV in the Hajj in Saudi Arabia. She's been all over the world. She is currently a senior fellow at the Schuster Institute for Investigative Journalism at Brandeis University, and she writes for many different organizations, including the New York Times Magazine, Smithsonian, The Atlantic, NPR, National Geographic, Wired, Scientific American, Nature, et cetera, et cetera, et cetera. She has written on epidemics and disasters from New Orleans and Hurricane Katrina to Arctic victims of the 1918 flu. And she has a clear passion for antimicrobial resistance. I hope many of you, if you haven't seen it already, check out her TED Talk from 2015, which is entitled, "What Do We Do When Antibiotics Don't Work Anymore?" which I think is very prescient to the discussion we're going to be having today. She's also authored a number of books, Beating Back the Devil, which is about the EIS Department of the Epidemiologic Intelligence Service within the CDC, where many of our staff, including King Holmes, who's in the audience, started their careers. They're also about Superbug, which is about staphylococcal resistance and the development in the early years in the 1990s and 2000s. And today she'll be talking about her more recent book, which is Big Chicken, which is the incredible story of how antibiotics created modern agriculture and changed the way the world eats. And I found it humorous that it's in the animal husbandry section, because I think there's probably 5 different locations where it could go in Barnes & Noble, but I thought this was kind of funny. But I think it really is a superb introduction to today's symposium, and I think we're really lucky to have her today. From the foundations of drugs like auramycin to the emergence of MCR1, colistin resistance, she addresses how we are our own worst enemy when it comes to antibiotic resistance. Perhaps more simply, when I think of Maryn, I think of somebody who makes science, the science of antibiotics, epidemics, resistance, and food safety digestible. And as scientists, I think many of us in this room can really learn how her dogged investigations and her ability to make important infectious disease issues of the modern era relatable is something we should all be paying attention to. It's also important to know that I have another bird to thank for Maryn, and that's the blue Twitter. I met her through this process. For those of you who are not interested in this, I promise you it is an important way in academics to communicate, and it's the way she's here today with us. So I think it's really important to point that out. And as with that introduction, I'd like to take a few minutes to welcome Maryn. Thanks a lot for coming.
Hi. Let me see if I'm at the mic. Okay. Thank you, Steve, for that fantastic introduction. I am incredibly flattered. And I'm a little bit embarrassed to realize that I am wearing the exact same clothing that I'm wearing in that Atlanta magazine shoot, down to the jewelry. That the chicken was so fascinated by. What you can't really tell is, first, you can't tell that it was 90 degrees that day, and I was sitting in a borrowed backyard next to a borrowed chicken coop, and second, that I am actually holding the chicken back from attempting to peck my jewelry off my fingers. Feisty bird. I am so thrilled to be here. I'm incredibly flattered by the invitation. Thank you so much. And thanks to Twitter for introducing us. Though, Steve, you said that we actually met at the CDC first before we re-met on Twitter. I'm sorry, I had forgotten that. And it's especially thrilling to talk about this in Seattle, because it turns out that Seattle and the Seattle-King County Health Department were really important in the elucidation of the story that I'm going to tell you. And Seattle is important in so many ways that I'm not going to be able to get into all of it, but it's all in the book. So just in case you want to know more about how Seattle was important to the elucidation of antibiotic resistance flowing from agriculture, there is this book that I wrote. But I'm going to tell you the story, the history behind some of the things that we're going to talk to today. And as is the case for people like me who are journalists, it's going to be kind of qualitative and maybe from your point of view a little mushy, but I hope it will knit together for you the narrative that brought us to where we are today. So here's where it begins. On Christmas Day, 1948, a scientist walked into his laboratory outside New York City to check the results of an experiment. And what he found that day changed history. It created the global system by which we raise meat animals for our consumption. And though he didn't know it at the time, it also created the conditions for a profound human health threat that would sweep the world. We are still grappling with the results of his discovery, which is that if you give tiny doses of antibiotics to meat animals as they grow, we can make them grow faster and protect them from conditions that would otherwise be bad for them. And we're still dealing with the unintended consequences of that process, which is the undermining of the power of antibiotics in what we all know as a global epidemic of drug-resistant infections. So this is that scientist. His name was Thomas Jukes. He was a native of England who emigrated to the United States, worked for a while at the University of California, and ended up in a pharmaceutical firm called Letterly Laboratories outside New York City. In 1948, he staged an experiment to find a dietary supplement that would allow farmers to give meat animals cheaper, less nutritious feed. And the way he did that was to take a bunch of just hatched chicks. Chickens are uniquely important to this story. He divided them up into groups in a classic experimental design, and to each group, minus a control group, he gave some supplement: crystalline vitamins, brewer's yeast, cod liver oil, and to one of the groups, the dried, ground-up remains of a drug that his company had just begun making, had just received the patent for. That drug was aureomycin, the first of the tetracycline antibiotics. When he weighed the chicks a few weeks later, he discovered that the birds who'd received the antibiotic manufacturing leftovers weighed more than any other birds in the experiment and had gained twice as much weight as the birds in the control group that received the standard diet. Jukes called this effect growth promotion, and he realized fairly quickly, though he did not admit it for several years, that what was creating the effect was tiny doses of his company's newly patented antibiotic, aureomycin, left behind in the manufacturing waste when the raw drug had been strained out. And with that recognition, Jukes created a new industry. Within 5 years, the amount of antibiotics that American farmers were giving to their livestock went from 0 to 500,000 pounds a year. And today, just in the United States, the total, according to federal data, is more than 30 million pounds, and globally it's believed to be more than 260 million pounds of antibiotics. On a global scale, averaging in countries that use a lot of antibiotic, countries that can't afford it, and countries that control antibiotics very tightly, of which there are a few. That's still twice as much antibiotic by volume going into livestock as are used in humans. And this is important. Unlike in human medicine, almost none of those antibiotics are going into animals that are sick. They're going instead for the effects that Jukes determined all those decades ago: to increase animals' growth, to make them put on tasty muscle more quickly, and to protect them against the conditions in the very large farms that grew from Jukes' discovery. That's important because, as everyone in this audience will already know, whenever we are using an antibiotic, we're taking the risk that disease bacteria will adapt to the drug and become resistant, will learn to protect themselves against the effect of the drug meant to kill them. When we give antibiotics to humans in the manner they were designed for, and even when we give them to a sick animal, as unusual as that is, relatively speaking, we are balancing that risk against the benefit of curing an infection. When we give antibiotics to animals in a subtherapeutic manner, there is no benefit because the animals are not ill. There is only that risk. So I came to this story out of writing, as Steve showed you the biography of drug-resistant staph. And in a couple of years of spending time with victims and the family members of victims that didn't survive, and researchers and clinicians, I heard a lot of messaging about how precious antibiotics are to us, what a gift they were, and how crucial it was that we protect their action. And I could not understand how, in the same space and time, we could be so concerned about protecting antibiotics for human use, and so flagrant in the way we give them to animals in the United States until recently, fully through over-the-counter sales. In fact, on my desk at home, I have a 2-pound bag of Oreomycin that I bought over the internet, and the only thing anyone asked me when I bought it was my credit card number. That would be a little more difficult now. This was about 3 years ago, before new rules that I'll tell you about in a minute, but probably still available. So I wanted to know, how did we get to this situation? And to describe how we got to here, I have to take you back to here, to the end of World War II, which also happens to be the beginning of the antibiotic era. I think most of us don't stop to think how recent antibiotics are because we were all born within the antibiotic era. Almost all of us since Alexander Fleming on 1928 looked down on that lab plate of staph that he was growing in his laboratory in London and realized that something had blown in the window that was creating dead spots in the lawn of staph, and that thing was Penicillium mold. So from 1928 to 1943 or so, not much happens. But in 1943, penicillin is rolled out on the battlefields of World War II and is a sensation. Hundreds of thousands of soldiers and sailors come back from the war who otherwise would have died. People who would have died, terrible lingering deaths from infectious diseases, are cured in days. Sometimes it seems in hours. So antibiotics are an enormous public good. And for most of their manufacturers, they are also a huge moneymaker. And that effect of finding a new, incredibly popular product dovetails with something else that's going on at the end of World War II. And that is a unique sense of fragility and instability in food production. So think about this. Millions of soldiers and sailors around the world need to be fed. Governments putting their armies and navies into the field encourage meat production to increase to feed them. And then the war ends, and that guaranteed market goes away, and meat production as an industry is left with all this new infrastructure and no sales to hold it up. So there's pressure suddenly to reduce costs. And there's another pressure that's going on at the same time, which is that because of the effects of the war, food production around the world feels threatened. Arable land has been ruined by battles. Flocks and herds have been decimated. Fishing fleets have been co-opted by navies that need extra vessels. There are famines and crop failures in Europe and Asia, and even here in the United States. There's a shortage of meat so acute that, as you can see, it's called a meat famine in headlines. It's so serious that it becomes an issue in the first election after the war in 1946. So between that sense of fragility and that sense of there being too much infrastructure, meat production wants to cut its costs. And what producers do is to start using cheaper feed, in the case of chickens, grain-based feed instead of pulverized fish fished from the coast of California. Grain-based feed is less nutritious, and so they go in search of less inexpensive supplements that will restore some nutrition to the feed they're giving to animals. And that's what brings Jukes into his laboratory in 1948, looking for a supplement and using his company's new drug, Oreomycin. Jukes and the cohort that come after him are convinced that they have solved the problem of food production and solved the problem of feeding the world after the devastation of the war. It doesn't seem to have occurred to them that there would be any negative effect from this new use of antibiotics. And I really find that extraordinary, because just a few years before, Alexander Fleming, the father of penicillin, perceived that these miracle drugs that he was the parent of were already under threat. In his speech accepting the Nobel Prize in Medicine in 1945, along with his collaborators, he warned that if we used antibiotics inappropriately, if we underdosed so that bacteria were not killed, antibiotic resistance would result. And though it was 3 years in advance of Jukes' experiment, what he was describing was what Jukes did in his animals and what other researchers and then farmers did immediately afterward. And it is extraordinary to me that this warning was ignored. I cannot believe it. It was so widely published that I cannot believe that Jukes did not know about it. And Fleming was right, because within 2 years of his voicing this warning, penicillin-resistant staph, which is a thing that has never before existed in the world, starts to sweep through hospitals. First in England, then in Australia, and then it comes to the west coast of the United States, and it causes a massive outbreak here in Seattle at Harborview. Those outbreaks are front page news in every country where they occur. They cause a panicked summit meeting in the United States, staff researchers brought together at Case Western in about 1957. So no one seems to have considered that the same processes that would cause antibiotic-resistant bacteria to emerge in hospitals will do the same thing on farms. The FDA approves these uses of antibiotics in livestock in 1951, and then a second license in 1953. And Jukes' effect of growth promotion, using antibiotics to put tasty muscle faster on animals, quickly becomes routine in farming in America and around the world. And not long after growth promoters become so popular, so do slightly larger doses for prophylactic or preventive uses, routinely fed to animals to protect them from diseases of crowding in newly enlarged barns and feedlots. And of course, this is a mistake, because the situation that Fleming correctly predicted for disease bacteria in humans occurs as well with regard to agriculture. Antibiotic-resistant foodborne illness, again, a thing that has never existed before, begins to sweep the world. The first sign of trouble is actually in dairy production. Children drink more milk than adults, and children who drink milk begin to develop penicillin allergies, even if they've never taken the drug, because there's so much penicillin in being given to dairy herds. Then cheesemakers begin to complain that they can't make cheese anymore because the penicillin in the milk is killing the beneficial bacteria that they use to develop cheese and cause the milk to coagulate. The first widespread outbreak of drug-resistant foodborne illness is in southeastern England. More than 100 people sick, 6 dead in cases in people who have no family or household or town connection to each other. And then finally, in a small town in Yorkshire, there's an outbreak that centers in that town's children, and 13 children die. That is so shocking to the United Kingdom that it becomes the first government anywhere to put any kind of controls on farm antibiotic use. They put together a commission in 1969. It's called the Swan Commission, after its chairman, who later went on to be the chairman of the BBC, Michael Swan. And they study the issue for 2 years up and down England, taking testimony from farmers and from researchers. And then they come out with a report which recommends that growth promoters should be banned. And any antibiotics used in agriculture should be only those that have no relevance for human treatment. And in 1971, the UK Parliament passes those recommendations into law, making the UK the first government anywhere to control farm antibiotic use. And at that point, attention naturally shifts to the United States, which is the home of growth promotion after all. And this gentleman, whom I think a number of researchers probably know, enters the picture. This is Dr. Stuart Levy of Tufts University, then and now, working at Tufts outside Boston. And he undertakes an experiment to prove that the concerns behind the British ban are legitimate concerns. He creates an experimental farm outside Boston. He finds a property, he buys a bunch of chickens, he locks them in pens so they have no contact with each other, and he hires a family to feed the chickens and keep track of what's going on. And then he goes to the feed store and he buys a bunch of feed. Some of it is drug-laced, very, very typical feed for the time, and the rest is drug-free. And he has the feed fed to different pens. Within a couple of months, drug-resistant bacteria appear in the guts, first of the chickens getting the drug-laced feed, then in the chickens getting the drug-free feed, and finally in the guts of the farm family monitoring the animals for him. Levy proves two things. First, he solves the mystery of antibiotic-resistant foodborne illness because he shows that routine antibiotic doses are affecting what we would now call the gut microbiome of those birds, turning bacteria toward resistance or increasing the proportion of bacteria that are resistant. That solves the mystery of foodborne illness because it illustrates that when the animals are slaughtered and gut contents splash onto the meat they become, those bacteria travel with the meat into kitchens and onto plates. But he also illustrates something that we still, I think, are grappling with today, which is that there's just as much danger when the animals are still alive because their gut contents, their manure, pass from the barn, from the animals into the barn, into the lagoon, or into a pile of litter, into the farm environment, and are carried from there, both the bacteria and the resistance DNA they contain, carried away by stormwater, by groundwater, by dust on the wind, on the feet of insects and rodents, and on the skin and on the clothing of farm workers themselves, allowing resistant bacteria to penetrate the environment in a manner that is untrackable and unpredictable. Levy's discovery briefly prompts the US government to try to do something in the same way that the UK government has done. It's 1976, the Carter administration, a crew of earnest young reformers have just been sent to Washington, D.C. And one of those earnest young reformers is Donald Kennedy, who later becomes the president of Stanford University. He proposes to take away the licenses that his agency, the FDA, granted at this point more than 20 years before to drug companies. And he never gets that chance because congressmen beholden to agricultural interests send a message up to the White House that if this goes ahead, in retaliation, they will hold hostage the entire FDA's budget. And so the White House sends a message back down to their earnest young reforming FDA commissioner that his action cannot proceed. And it doesn't. And at that point, we enter a stalemate in the United States that really only ended last year. And the US and the UK and the Scandinavian countries and the rest of Europe fundamentally diverge in their attitudes toward farm antibiotic use. After the UK, the Scandinavian countries enact bans in the 1980s. The entire European Union does a partial ban in 1999 and a full ban in 2006. And here in the United States, we go the empirical route and wait to see what is going to emerge. And of course, outbreaks do. In 1987, hundreds of people fall ill in California as a result of eating ground beef from exhausted dairy cattle, cattle that have been dosed to keep them going for a little while longer with the antibiotic chloramphenicol. Across the 1990s, thousands of Americans develop infections from salmonella that's resistant to fluoroquinolones, which means that when they go for treatment to their physicians, the first choice drug, Cipro, a fluoroquinolone, is no longer available. Starting in about 2001, researchers first at Berkeley and then in Minnesota begin to prove that some portion, possibly 10%, of the millions of urinary tract infections that occur in the United States every year and proceed in some cases to kidney infections, bloodstream infections, and even death from septic shock, are due to bacteria traveling on meat. And in just the past decade, researchers across a number of farm states in the US have begun to prove that resistant bacteria, as Levy suspected, are moving away from farms in runoff, on the wind, on the backs of trucks, in the bodies of farm workers and are affecting adults and children who live near large farms, whether they actually have a personal connection with those farms or not. In just one outbreak, which I think is probably quite familiar to people here in Washington, in 2014, 638 Americans that are known to have been diagnosed, probably several thousand who are never identified, if you accept the CDC's multiplier for foodborne illness, are made sick with drug-resistant Salmonella Heidelberg originating in one slaughter plant of chicken in California. And these outbreaks like this are not confined to the United States. So in 2004, in the Netherlands, a new form of staph that is tetracycline resistant begins spreading from intensively housed pigs that have been dosed with tetracycline. This tetracycline-resistant staph moves from pigs to pig farmers, into their families, into the wider society, and causes an outbreak in Dutch hospitals, which otherwise have very low rates of MRSA, so profound that the Dutch government decrees that if you are a pig farmer and you have to go to the hospital, you will be instantly placed into isolation to be sure that you are not a threat to the rest of the patient population. In some towns close to the pig farming areas, they run out of isolation rooms. And in 2015, Chinese researchers working with researchers from the University of Cardiff show that a gene has appeared that confers resistance to the absolute last resort drug colistin. And that gene is in bacteria that is being found at the same time in pigs, in retail pork in markets, and in people. And that gene, MCR, has now moved in bacteria around the world. It's been found in more than 35 countries and has caused infections, including here in the United States. So while these epidemics have been expanding, one other thing is happening that I think will be very familiar to people in this audience, though it's not to most people I talk to. And that is that it's possible that society didn't take antibiotic resistance flowing from agriculture as seriously as we should for as long as we ignored it, because we assumed that however bad resistance might get, there would always be another drug to fix it. And that is no longer the case. Pharma companies, for the most part, have stopped making antibiotics because they reasonably see that they are no benefit to their bottom line. If it takes 10 years and $1 billion to produce a new antibiotic, working against bacteria that can have a new generation every 20 minutes, how long will it take before your drug loses its power? Certainly less time than it will take to make back your R&D budget. So in that endless game of leapfrog between drugs and bugs that began with Fleming's perception in 1945, the bugs are ahead. We are not doing enough. We have not done enough to control their evolution. And so it's been estimated, as Steve referenced some of these numbers, that right now the toll of antibiotic resistance worldwide is 700,000 deaths a year. 23,000 in the United States, that's just deaths, not those more than 2 million visits to healthcare, 25,000 in the European Union. And that review on AMR, sponsored by the British government, predicted that by 2050, the toll may be 10 million deaths and a cumulative loss to the world of more than $100 trillion. So, as a journalist, this is kind of a thing we do. We're always looking to concretize statistics for people. So let me concretize these for you. 700,000 deaths a year is an average-sized large aircraft, 300 people, crashing every 6 hours. 10 million deaths a year is an aircraft carrying 300 people, the kind of aircraft that brought me here on Tuesday morning, crashing every 15 minutes all around the year and killing everyone on board. The calculation done by the folks who came up with this number is that 10 million deaths a year is one death every 3 seconds all around the world. And that is dramatic. But what I think we don't think about enough is the effects of antibiotic resistance that would be less dramatic than the equivalent of many plane crashes. whether we realize it or not, by our overindulgence in antibiotics, and we know that medicine has some blame here, but of course, I believe agriculture has more, we have brought ourselves to the edge of a world in which we lose most of what we think of as modern medicine, and lose as well most of the confidence with which we live our everyday lives. You will know this intuitively in an institution like this, but if we lost antibiotics, the first thing we would lose would be people with compromised immune systems. Not just cancer patients, but HIV patients, premature babies, people who've received transplants. We would lose the treatments we rely on that install foreign objects in the body, so stents for stroke, pumps to deliver insulin for diabetes, replacement joints. We'd lose many surgeries. We might lose even some dental care. And this is the part that's fascinating to me. We would learn to fear again things that we no longer think of as important. Strep throat used to cause heart failure. Pneumonia killed 3 children out of every 10. Giving birth in the cleanest hospitals killed 9 women out of every 1,000, often many more. Scratches could lead to limb amputations. The first patient to unsuccessfully to receive penicillin experimentally and almost survive, but then die because the amount of drug ran out, was scratched on his face by a rosebush thorn. And what I think about is, what would we do? How would our lives change if we thought that any minor injury was a deadly risk? Would you ride a motorcycle? Would you bomb down one of the ski slopes that aren't very far from here? Would you let your kids slide into home plate? Would you climb a ladder to hang your Christmas lights? Those are the things that are threatened by our overuse of antibiotics that I think we do not think about. And here's the thing that I think is particularly important for this part of the world. The origin of problematic antibiotic use in agriculture is in land-based protein, chicken and cattle and hogs. But what is true on the land is equally true in the sea. In some parts of the world, aquaculture, both for finfish and for shrimp, are heavily dependent on antibiotics. I just came back from speaking in Chile, where the salmon industry is struggling with its antibiotic use and losing international reputation as a result, and also losing large international contracts. Costco has just ceased buying Chilean salmon for most of its supply and has switched to Norwegian salmon, which has a much lower rate of antibiotic use. And of course, the problem is not only in Chile, because salmon farming just across the border in British Columbia is also reliant on antibiotic use to keep down disease in open water pens. That industry, as recently as this past year, has been determined to be reliant on routine antibiotic use. Most large-scale production of protein still is. So that is a danger that we all must deal with, because the large-scale production of protein is growing around the world. As economies of emerging nations improve, their new middle classes are buying more meat with the money they are making. It is an incredibly predictable signal of an improving economy that meat sales rise. So it's natural for those countries, Brazil, India, China, Southeast Asia, to turn to intensive forms of meat production. And it's natural also for them to turn to routine antibiotic use to uphold those systems, unless they can be taught a different way. Most of the global south has not yet put any kind of curb on antibiotic use in its agriculture. Brazil is now the world's largest exporter of chicken and one of the largest users of antibiotics in livestock. China is already the largest user of antibiotics in livestock, and it's been predicted that if that trend does not change, by the year 2030, China will be using 30% of all of the antibiotics made in the world in its livestock. So, all nations, I think, now have to confront these questions for the good of the world. Can very large protein producers change their habits, and can governments find the political will to encourage them to do so? And here's the point where I tell you that there may be a happy ending, so you don't all have to be as depressed as you feel like you are right now. I mean, just reliably at this point, the temperature in the room goes down, way down. In 2014, the chicken company Purdue Farms, which is the 4th largest poultry producer in America, shocked the rest of its industry by declaring that it was going to go antibiotic-free. And now, almost 4 years later, they are more than 99% antibiotic-free in the millions and millions of chickens and turkeys that they produce every year. They have been followed by Tyson and Cargill and Pilgrim's Pride and Foster Farms, and by Chick-fil-A and Subway and Taco Bell, and most of all, by McDonald's. In 2016, the central government of China, which was alarmed and embarrassed by the news of that multi-drug resistant bacteria emerging from its agriculture and spreading around the world, declared a unilateral ban on the use of the drug colistin, that last resort drug that was being used preventatively in its agriculture. With that action, they took more than 8,000 tons of the drug out of availability from their farmers and set an international precedent. And in January 2017, 1 year ago, in one of its last acts in office, the Obama administration created a ban on the use of growth promoters in the United States, ending that 40-year stalemate that began with the Carter administration in 1977. So those are encouraging moves, and it is critical that more of them happen. Almost no government has addressed the preventive use of antibiotics in agriculture. Only a few have, the Scandinavian countries and the Netherlands among them. Most, including here in the United States, continue to allow preventive use in animals that are not sick. Just last month, the World Health Organization asked governments around the world to please stop doing this, to cease using antibiotics critical for human health in animals that are not sick. And among the responses they got was from the Trump administration, which said no. So, nevertheless, this is a problem that will not go away. The movement of resistant bacteria around the world shows us that we can no longer pretend that one country or one ecosystem is separate from another. Foods are flown around the world. Pathogens cross borders, in birds, in the oceans, on the wind, and in our bodies. The great microbiologist Joshua Lederberg once observed, "There is nowhere in the world from which we are remote." For the overuse of antibiotics, we have not learned that lesson. And I think we do not have much time to get it right. Thank you very much.
Thank you, everyone. Thanks, Maryn. That was a great introduction, as I mentioned. She is, when she scares me, it's always bad, right? So I want to ask the panelists to come take their seats. I think, Marissa, I'm going to have you sit here. Okay. Peter is next to you, Doug in the middle, and then Catherine and Scott at the end, okay? And what I have is I'm not, I would introduce you all, it'd be difficult, so I'm going to let you introduce yourselves. So I put you in this order because this is the order of your slide decks to make it easy. That's how we've done it. And I also I wanted to put the some of the clinicians on one side, public health, and then One Health, and our folks from WSU in the middle, because they're really, I think, critical to this discussion. So let me pull up Marissa's slides, and we're going to keep you guys to your 5 to 7 minutes because we want to get to some questions, which I think are really important. So I'll let you introduce yourself, Marissa.
Okay, great. So, good afternoon, and thank you very much to Steve and Scott Weissman for inviting me to talk today. And thanks, Maryn. I'm really impressed with the book that you wrote, and I was scared after hearing you talk. So I have a lot of slides, so I'm going to try to zip through them. So I'm from the Washington State Department of Health, and actually many of my colleagues are here today as well. So I wanted to just start with talking a little bit about the strategies that we use to combat antibiotic resistance at the Washington State Department of Health, and they are detect, protect, prevent, innovate, and collaborate. And so just going through them quickly. So detection is not only the lab testing to identify antibiotic resistance, but also the astute clinicians who pick up something unusual about a patient or realize that they have an unusual travel history, or that an infection preventionist noticing that there's some cluster occurring in a healthcare facility. Protect has to do with excellent infection prevention in healthcare facilities and also immunizations to prevent infections from happening. Prevent, we focus on antibiotic stewardship to prevent antibiotic resistance from occurring. Innovate has to do with developing new lab tests, new antibiotics, and new methods for preventing infection. And then collaboration, working with other groups to move this struggle forward. So at the Washington State Department of Health, there are many different divisions. I work in disease control and health statistics, and that's where communicable disease epidemiology and the healthcare associated infection program are. That's where I work, and also the public health lab. And so these are the things that I work on, and some of the colleagues here with me today. So we perform surveillance for multi-drug resistant organisms under our notifiable conditions. Surveillance, particularly for carbapenem-resistant Enterobacteriaceae and carbapenemases, and then some of the more recently described unusual organisms emerging infections and resistance, such as MCR and also Candida auris. We also track and respond to healthcare-associated infections and infectious lapses in healthcare facilities. And then we also work on promoting antimicrobial stewardship in all healthcare settings. So I wanted to just show you a couple of slides of our CRE surveillance. So this would be, for example, like the KPC and the NDM that Maryn described in the book. And we've been doing surveillance for CRE since 2012. And I don't want you to pay as much attention to the height of the bars because we have used some differing case definitions over the years. So the height of the bar is CRE, and the pattern at the top is the carbapenemase producing isolates. And you can see it makes up about 10% of the CRE that comes into the lab. And then breaking it down by carbapenemase type, these are the carbapenemases that have been identified. And you can see that KPC is the most common, and that is actually the US homegrown carbapenemase that has since spread all over the world. And then NDM appears to be the second most common. So anyway, just a quick snapshot of our surveillance, and happy to talk about it more in the future. So anyway, disease control and health statistics also comprises the public health lab, and that's where all the specialized testing for antibiotic resistance happens. As part of CDC's and the US government's new efforts to contain and understand antibiotic resistance, they've created the Antibiotic Resistance Lab network, and our lab is the Antibiotic Resistance Lab for the western part of the United States, including all those states there on the, let's see, left side of the screen. And we also cover Guam, which I think is kind of exciting. And so those labs do particular testing in their states and then send the more unusual isolates to our state for other testing. Then I wanted to just talk briefly about some of the other things that go on at the Washington State Department of Health. So tracking foodborne illness and then responding to those clusters to make sure that we can identify what the cause is and also stop it. As part of that foodborne illness monitoring, isolates from foodborne illnesses are sent to the public health lab and then up to CDC for specialized testing to figure out what is going on and also to be able to identify clusters. So the testing that happens is antimicrobial susceptibility testing, and in that way we monitor developing antibiotic resistance in those organisms. And then also PFGE to look at the DNA fingerprint and put clusters together. And new as part of the ARLN work is doing whole genome sequencing on those as well. Then our ZD program tracks and responds to illnesses in people that are coming from animals. And so just a couple of the examples are Salmonella from chicks, Campylobacter from puppies from pet stores, and also E. coli from petting zoos. Time check, how much longer? A minute?
Maybe another slide.
Okay. Anyway, so other efforts at the Department of Health include work on food and water safety, the immunization program, health professions and facilities. And just to actually, I can't go previous. That is regulation of healthcare facilities to make sure that they're obeying laws and doing things safely to keep you safe in healthcare facilities. And then I know Peter's going to talk more about One Health, but I did want to just mention that we have a One Health, the Antimicrobial Stewardship Work Group. And I brought our vision and mission statement. I don't have time to go through it with you, but maybe we can share it more later. And then finally, some resources that are really interesting about antibiotic use and labeling of meat and stuff like that. So anyway, thank you very much.
Great.
Great, thanks. So, thanks Marisa for mentioning One Health, and thanks Steve and the other organizers, and for Maryn for coming to really raise awareness about this incredibly important issue. And on page 99 of Big Chicken, you mentioned that people looking at antibiotic resistance several decades ago started realizing that this is not a problem just in people. This is a problem that involves what's going on in animals, and it also involves the environment, and that more recently we need to really not talk about animal health over here and human health over here and the environment somewhere else, but look at it in a much more unified way if we're really going to do something about this. So this is a CDC slide talking about the fact that there is this constant cycling of bacteria and the use of antibiotics between humans and animals and the environment. And so it's been realized, but I think, Maryn, you sort of express amazement that somebody working in animal health is not totally necessarily aware of what's happening in human health, and there's always reasons for one occurrence, but I think traditionally we have to acknowledge that we really have worked in silos on this issue for a long time, and part of it's political, part of it's professional, the way we're trained, the way we work. There's usually a human health agency dealing with the people, animal health dealing with the animals, and then some environmental health agency working with the environment, and we are not used to working together, but antibiotic resistance is really telling us that this is all connected and we have to work together in ways we haven't done before. And that's what is sort of pushing this idea of, instead of human, animal, environmental health, we're really dealing with a One Health situation. And this concept has been endorsed by WHO, CDC, and USDA as sort of agreeing that we do need to work together. And also from the recent Obama White House task forces on antibiotic resistance that said, you have to take a One Health approach to this issue or you are not going to solve it. So that sounds really great to get everybody working together. One of the things that when you try to work with different professions, I think you have to realize that we all have something to teach each other and to learn from each other. And this is what we're trying to do in Washington State, because a couple of years ago, we set up a sort of steering committee of different agencies in the state to work together on issues. The big issue that everybody agreed we needed to work together on was antibiotic resistance, but at the beginning we had to kind of make a pledge that we were not going to point fingers, that we were going to actually try to learn from each other and work together, and that's what we're doing. Just as an example, most of us here are healthcare professionals and things. How many people drink organic milk? So I often buy organic myself. If you drink organic milk and a cow on that organic farm gets an infection, what do you think happens? What's that? They receive antibiotics. Okay, so it has mastitis, very common infection in cows, not good. Receives antibiotics, what happens to that cow then? What's that? It's not organic anymore for the life of that cow. So that cow, two things happen. It either goes to hamburger or it's sold to another person to raise non-organic milk. So for the life of that cow, it cannot receive antibiotics. So there's some funny things that happen on some organic farms that we all think are great because they're not allowed to use antibiotics. And so just remember that we don't always know a lot about farming, and organic sounds great, but there's some issues. So we decided to look at what's going on just in our state. Instead of pointing fingers, we wanted to try to look at data. So think about, here's Washington State, and as Maryn said, there is fish farming going on in, we're actually the second largest state in the country for aquaculture after, I think, Louisiana with catfish. But we're number 2. A lot of it's shellfish, but a lot of it's salmon. Antibiotics are being used there. We're actually spraying antibiotics on fruit trees, so it's not all animal production. We're using antibiotics to grow apples and cherries and things like that in here. And we're using it in human health, and we're using it in animal health. So we have to try to pull that together and see where's the problem. And one thing we decided to do is actually look at data in our state and try to understand that. And you'd think that these days we'd have all the data and we could just understand exactly what's going on. We've just developed an integrated database to try to bring it together from all these different sectors. And we're actually looking now at the data. There's a lot of missing gaps. We're not gathering data all the time, not just on animals. We're also know very little about the 2/3 of antibiotics in human medicine that are used in the outpatient setting rather than hospitals. So we're trying to actually look at numbers and try to do something about that. And it's bringing up the fact that the picture is complicated, where the antibiotic resistance seems to be worse, how we can do stewardship across sectors. But we are, for the first time, having a sort of a summit meeting this spring sponsored by Maurice's program at the Department of Health, which is really helping support this database too, to bring together people from agriculture, people from human health, people from the environmental management as well, to say how in each sector, how's things looking according to the data we have here, how can we learn from each other. Agriculture, as Maryn said, is pivoting to try to raise large numbers of animals that the world is eating right now in a way that doesn't require antibiotics, and that requires some learning that may actually tell us something about how to have a lot of 9 billion people on the world and use less antibiotics for them too. So I'll stop there.
Thanks, Peter.
Thanks.
Well, thank you very much for the opportunity to speak with you today. I'm Doug Call from Washington State University at the Paul Allen School for Global Animal Health, and I've taken a slightly different tact on my introduction. I just kind of wanted to tell you a little bit about myself and what we do, and then I want to make a couple key points that I think are worth discussing a little bit more as we move forward. I've been working on antimicrobial resistance questions at Washington State University since the year 2000. And we work on everything from antimicrobial resistance gene function and regulation to biofilms and skin wounds and a variety of organisms. And currently I spend a lot of time thinking about the epidemiology of antimicrobial resistance, particularly in the context of developing countries in Kenya, Tanzania, Guatemala, and a little bit of work in Brazil. I also want to make a plug for the Washington Global Health Alliance's Antimicrobial Resistance Coalition, which is many people in this audience are members of, and it's really an organization that is trying to educate our congressional delegation on the importance of this problem and the need for investing in solutions. I also just wanted to mention that the funding over the years that I've worked with has been primarily federal. In fact, right now most of my work is funded by the CDC overseas, but we also are funded by the USDA, NIH, DOD, NSF, and we work cooperatively with a variety of foundations. And you'll notice I have two industry pieces here, pork checkoff and beef checkoff, and I just want to point out to you that those were investments they were making in alternatives to antibiotic resistant, medically important antibiotics that we were working on some ideas with them for. So there is interest across all of these organizations in finding solutions. I also just want to mention briefly that I thoroughly enjoy working with heritage organisms, which were highlighted in the book quite a bit, and this is just some idyllic pictures of the Palouse where we don't have traffic jams. So what are my four main points I just want to cover real quick, and again, these are good conversation points I hope we can come back to. So I think we are moving in the right direction, and so it was pointed out earlier the FDA's come out with new rules. It's called Guidance to the Industry number 213, which basically said we can't do growth promotion anymore, and if you're going to put antibiotics into food and into water, you have to have a veterinarian involved. And by the way, that relationship with those veterinarians has to be renewed on a 6-month basis. Before, it was over 2 years. So there's got to be a give and take. A relationship has to exist in order to use these antibiotics. And if you compare these data just came out in December of 2017 from the FDA, and this is sales data, which we assume roughly reflects use data. Nearly 1.6 million kilograms less antibiotics was sold in 2016 versus 2015. This probably reflects the commitment by a lot of these large poultry producers to stop using antibiotics, which, by the way, is driven by you folks. Your consumer demand is forcing a change in an industry. They're reducing the use of those antibiotics. Whether it's enough or not, we aren't going to know for quite some time, but at least it's moving in the right direction. And I think we can expect further improvements under this. By the way, part of this is also the spin-up of the 213 regulation. We're going to get ready for it, so we're going to start using less antibiotics. 217 is the first full year's data that we haven't seen yet, that we're going to see how much difference it really made. But I think it's going to make a pretty big difference, because 69% of the antibiotic sales are for food and water administration, which means there's going to be a veterinarian involved in those decisions on that mass flock or herd-based applications. Another point I want to make is that large-scale vertically integrated food distribution will always be a risk for transmission of foodborne pathogens. There's no way to make this perfectly safe. It's a numbers game. It's a matter of probability. It's not a matter of if, it's a matter of when that we're going to have outbreaks. So one thing that doesn't come up in discussion very often, and I'll just throw this out, being the parent of 3 children who are going through an excellent school but couldn't really tell me what a bacterium is or antibiotic resistance, is, oh, by the way, small-scale producers are not immune to this either. We need to reinvigorate consumer education about food safety so we can also do a little better job protecting ourselves. How we handle food in the kitchen, how we handle food in restaurants and so forth, which are better than most, but certainly at the household level, we can do a lot more to help people understand how to protect themselves. I'm not saying that we should make people willing to accept contaminated products, just accept the fact that sometimes they will be, and you can do a better job of protecting yourself and your family. So a third point I want to make is that different antibiotics present different risks. This is important because it means we have opportunities to change behavior and choices of how we use antibiotics to have less impact. And just as an example, we ran a study where we treated dairy calves with a therapeutic dose of different antibiotics just to look at what happens both in the feces and in that environment where they're in, the pens that these calves are sitting in. And a drug called fluorophenocal, which is the veterinary analog to chloramphenicol, just a standard application of therapeutic dose, which is typically used for respiratory disease, resulted in over a 10,000-fold increase in the number of antibiotic-resistant E. coli shed in the feces. 10,000-fold increase per gram, and it stayed that way for about 2 weeks. In the soil, 10 million-fold increase. 10 million-fold increase in the number of resistant strains sitting in the soil where those animals are mucking around. And that stayed steady for over 30 days that we monitored. So that's a place where we can think about how to control these things at one level, or think about alternative treatments. Ceftiofur, 1,000-fold increase in both of those compartments. Injectable oxytetracycline, no impact, no measurable impact at all. There are cases such as respiratory disease where oxytetracycline can be substituted for Ceftiofur or fluorophenocal, and you would have far less impact on the enteric flora. Just an example of something to think about. We can be smarter how we use these antibiotics, and we do need to investigate incentives for having producers jump on board with these ideas. Finally, I want to say that globally the picture is not good, as highlighted briefly here. First of all, we think about the population size. Those bottom 2 bars, United States and Europe, represent probably the only 2 large governmental collection of governments that are actually paying a lot of attention to this problem. That LMIC, that's low and middle income countries, represents the other portion of our world. 80% of humanity lives in these places where, at least in low income countries, there isn't as much vertically integrated agriculture with a lot of antibiotic use, but it will grow. Because once you have the economic wherewithal to do this, it's going to be adopted. Just as an example, I work a little bit in Brazil, and just in one farm that I was at, this is for swine, animals from weaning to the point 4 weeks before slaughter, they're on therapeutic doses of antibiotics the entire time, amoxicillin, fluorophenocal, macrolide, tetracycline. This is just an insurance policy they're using because they can. It's to keep them from getting primarily respiratory diseases in this particular case. and then they can get into slaughter. And if they don't make it, they throw them back on doxy and get them safe again, or healthy again, and then send them into slaughter. So there's a lot of medically important antibiotics there. So at some level, we always want to talk about stewardship and how we manage how the antibiotics are being used, but in our work in Tanzania and Kenya, we're actually finding the bigger issue is the transmission of these bugs. We can't even find a signal from the use of the antibiotic on the individual or household level, but we sure do see it from the transmission standpoint. Bugs being transmitted between people, between animals, and so forth. I mean, it really boils down to good sanitation and hygiene. Stuff that isn't sexy, that doesn't attract a lot of attention in terms of funding and efforts, but if we don't get a handle on that, stewardship alone is not going to help us much in this situation. So,
So thanks so much, Steve, and to the organizers for pulling together this terrific symposium. Really a wonderful opportunity to be together in this room with people from all disciplines. So I'm going to switch gears now and talk a little bit about how we're working on tackling antibiotic resistance here at our Cancer Center. I am the Director of Antimicrobial Stewardship at the Seattle Cancer Care Alliance. And just to go quickly, some background that I think Steve has covered already, we know that antimicrobial agents have really transformed the care of cancer and chemotherapy in stem cell transplantation, allowing for the prevention and treatment of once life-threatening infections during our patients' most vulnerable periods. Our patients are frequently exposed to antimicrobial agents and are thus at increased risk of colonization and infection by multi-drug resistant organisms. There are also emerging data to suggest that antibiotics play a significant role in disrupting the gut microbiome, which has a potentially adverse impact on chemotherapy as well as transplant-related outcomes such as graft-versus-host disease. And for these reasons, antimicrobial stewardship must be recognized as a key priority among our cancer patients. And just to give you a sense of the burden of antimicrobial use in our patient population, this is a study that looked at the top 1% of inpatients receiving antibiotics. 100 out of 10,000 patients contributed to about 50% of the total antimicrobial expenditures over a 6-month period in a single center, $900,000 of the antimicrobial budget. And when this, the study drilled down further on the patients that consume these antibiotics, 2 out of 3 patients were hematology, oncology, or transplant patients. So our patients contribute substantially to antimicrobial use in the hospital setting. Our patients are at very high risk for antimicrobial resistance, and I'm just going to highlight the 4 C's of antimicrobial resistance threats in cancer patients. CLABSI, or central line associated bloodstream infections, CRE, which Marisa already talked about, Clostridium difficile, and Candida auris. So central line associated bloodstream infections, our patients are at very high risk for by virtue of the fact that they all need central venous access for administration of chemotherapy. In a recent study out of the CDC, oncology patients with CLABSIs were at higher risk than non-oncology patients with CLABSIs for certain types of multi-drug resistant organisms, including those due to fluoroquinolone-resistant E. coli and VRE. CRE, which is a pathogen of major concern both globally and here in the United States, was identified in a multi-center study out of New York, New Jersey, one of the hotspots here in the United States, to account to basically, in this study of patients, 50% of the patients were cancer and transplant patients. The mortality rate was about 50%, so very high mortality rate in a very highly vulnerable patient population. Clostridium difficile infection, a consequence of disruption of the gut microbiome, is the most common bacterial complication after allogeneic stem cell transplantation, with antibiotic use being the most important risk factor, seen in about 1/3 of patients post-transplant. And finally, Candida auris, already touched upon as well, an emerging multi-drug resistant yeast that is incredibly, can be very challenging to treat, a cause of outbreaks in healthcare settings. There's been at least 1 report in a hematopoietic stem cell transplant patient who died out of from this infection. And so I think this is clearly a major problem in our patient population. How do we begin to tackle the problem of antibiotic resistance in our cancer patients? I think the first step is to recognize that inappropriate antibiotic use is a patient safety issue. And I think we need to look at this on sort of both ends of the spectrums, recognizing that for patients who do need antibiotics, we want to make sure that they get the right antibiotic in a timely manner, and that for patients in whom antibiotics are not indicated, that they do not receive antibiotics. And for patients in whom antibiotics are indicated, we need to think about the 4 Ds of antimicrobial stewardship. We want to make sure that the patient gets the right drug, using the right dose, for the right duration, and for the right diagnosis, with the ultimate goal of improving clinical outcomes, reducing costs, and reducing the risk of antimicrobial resistance, both to the individual patient as well as subsequent patients. This is our antimicrobial stewardship team. We're very fortunate to have grown over this last year. We have Anya Sweet, who is antimicrobial stewardship pharmacist, Elizabeth Krantz, our biostatistician, Erica Stoes, who is our infectious disease fellow. We also have Sarah Marquis and Trent McAllister, who were recent MPH grads who have moved on in their career pathways but played an important role in helping to support the database development for our program. Jacqueline Zier is the newest member of our team. It's important to recognize that antimicrobial stewardship is a multidisciplinary collaboration, so we work with a variety of groups within the organization, work very closely with Steve Pergam and his group in infection control, the Department of Quality and Safety, pharmacy, IT clinical analytics, microbiology plays a significant role as well, in addition to our providers and external partners at, in antimicrobial stewardship in our partner institutions. And I just want to end by talking a little bit about some of the antimicrobial stewardship initiatives at the SCCA, focusing on optimizing the 4 Ds of antimicrobial use. We've worked on developing, revising, and updating clinical practice guidelines and pathways for management of febrile neutropenia and sepsis. We have an initiative right now to look at antibiotic allergies pre-transplant to make sure that patients are actually getting the appropriate antibiotics. In many cases, patients who report they have allergies don't actually have true allergies and can be actually delabeled. We're also starting this year a prospective review of targeted antibiotics by providing feedback to providers on dosing and optimized treatment. And then finally, we are also doing some work to improve knowledge about antibiotic use and resistance among our provider staff and patients through a variety of forums for provider staff education as well as patient education. And I'll go ahead and stop there.
My name is Scott Weissman. I'm the Director of Antimicrobial Stewardship at Seattle Children's Hospital and a member of the Infectious Disease Division there. These data are intriguing. This is a map of the United States, and it's a heat map that shows greater numbers or greater frequency of outpatient antibiotic prescriptions as a deeper blue color. And you can see that there's quite a bit of variability across the United States. I think the great thing is that we have these data. We don't understand them. I certainly don't understand them. What makes for these variables, this variability in prescribing across the country? You could come up with any number of fascinating hypotheses, and probably many of them are correct in various parts and at various times. But I think the overall number is really remarkable. And so Maryn was talking about concretizing statistics, and I think the way they've divided this is helpful. So if you think about 1,000 persons in each state every year, in the regions of the Northeast, where I hail from, there are 830 antibiotic prescriptions given out each year. So that's not quite one per person, but it's getting there. In the Midwest, similar numbers, 868 for each 1,000 people each year. In the South, the highest numbers, 936, and some of the component states in the regions do well exceed one prescription per person per year. And for some reason, in the West, the prescription density is lower. And I think, so what is it? Is it something we're doing right? I think we don't understand. And until we have a better understanding, I think there's very little to trust here. It's nice, but it's like being, waking up on third base and thinking that you've hit a triple. We don't know what it is. It could be geography. It could be any number of things. If we break it down even further into age clusters, we'll see that for each American citizen, each American patient, there are differential risks of being prescribed an antibiotic over the lifespan. And it is in the pediatric population, which is the closest thing that human medicine gets to veterinary medicine, is treating children. You could almost argue that we are doing the thing that they do in agriculture, which is feeding our young antibiotics. They have the highest density of prescriptions during the first year of life, and that abates somewhat over the course of the subsequent decade, so on and so forth, until you get into the over 65 category, at which point physicians and prescribers start to really ramp up that prescribing again. And if you break it down another way by period, the rightmost column gives you kind of the average number of prescriptions that an American patient will receive over that time bin. So an average of 2.7 prescriptions will be received in the first year of life. By the time you're 10, you've had 10.9. By the time you're 20, you've had 17, and so on and so forth, on average. Your individual results may vary. That's the beauty of statistics. But the numbers are really quite striking. So antimicrobial stewardship has been put forward as the last best hope. And I think of stewardship as really how we protect our patients from us as prescribers. How we protect them from our urges to prescribe. Because it is increasingly my abiding belief that if you prescribe antibiotics, you by definition overprescribe antibiotics. That's the way we've been trained. That's the way agriculture was built, and that's the way modern medicine is built, on these practices that we assume are given and handed down to the point that these practices are invisible as the air that we breathe. So we are learning steadily how to build this kind of protective function into our hospitals and into our outpatient clinics to span the human medicine domain. And now the Centers for Medicare and Medicaid are now basing their remuneration for hospitals as a condition of participation, requiring that hospitals have these stewardship programs. And soon, similar structural incentives or disincentives will be established in the ambulatory setting as well, for sure. Stewardship has always been a good idea. Now it'll be a good idea that's required. And that's from Arjun Srinivasan at the CDC. Great line. So just briefly, this editorial came out a year or so ago from Brad Spellberg, who's down in Los Angeles and one of the kind of outspoken thought leaders in antibiotic prescribing behaviors. And he wrote, in AD 321, Roman Emperor Constantine the Great codified that there would be 7 days in a week. And so on and so forth. This 1700-year-old decree remains a primary reference for the duration of therapy. It leads physicians to treat infections in intervals of 7 days. We also throw in the multiples of 5, 7 to 10 days, 10 to 14 days, 14 to 21, and so forth. And really, these are some practices that were entrenched as early in the antibiotic era as 1945, where investigators decided that they would treat pneumonia until the patient had defervesced, until the fever was gone, plus some more, with the idea that that plus some more really was important. And the rationale for that was based on data and observations that we really didn't have the ability at that point to really say that patients who became infected again were being infected by the same organism that had been undertreated according to Fleming's warnings. But these practices nonetheless have been in the DNA, as it will, of antibiotic prescribing in medicine for some 70 years. Yes, yes, animation. So this is dogma. And now we are starting to move away from this dogma, and we're looking for the evidence and the strategies to help us with these behaviors. I want to finish by saying that we now understand in human antibiotic stewardship that prescribing is a social behavior. It's an emotional behavior. It's not simply a physician looking at the facts and weighing the options and doing some calculations on an envelope about risks and benefits. This is a social behavior, and these are entrenched patterns that are largely invisible to us at the individual level. We are the fox in our own henhouse. And this work has really, the work in behavioral economics has shown us some of the shortcomings of our own cognitive processes, and some of this work is now being leveraged in antibiotic stewardship to help us understand how the limbic system, how our emotional behavior drives antibiotic prescribing, and maybe we should really just be prescribing ourselves anti-anxiety medications and sparing our patients. I'll conclude there.
So I want to introduce Paul Pottinger, who's the Director of Antimicrobial Stewardship, who will be helping to lead the discussion. I encourage anyone in the crowd who's got questions. Just so you know, we do it a little differently here. This is the microphone itself. It gets tossed around. It's soft, don't worry, but please tell someone before you throw it. So if anyone has a question to start, please raise your hand and I'll bring it up to you, and then you get to toss it on to the next one.
And if anyone has a cold, please don't touch it.
So, do you want to? I'm gonna let Paul start with the question so you guys can get warmed up. Okay? So Paul, go ahead.
I think they're plenty warm. So, point of clarification: I'm co-director of Antimicrobial Stewardship at UW Medical Center with Rupali Jain, who's our ID pharmacist. I think she's joining us on Facebook now. So here's what I want to start with. I'm going to pitch a question, getting back to something that Scott talked about a moment ago. And this is both to Dr. Call and Dr. D'Angeli, whatever order you want. Let's talk about that very light blue state in the upper corner. Why are we, with the exception of Alaska, good on you Alaska, why are we the lowest consumer on a per capita basis of antibiotics? What's up with that? And how does that translate? Does it? Did we wake up on third base? Why is it that our drug resistance rates are comparatively low looking at most other states in the nation? Marisa, you showed that nice slide of some bad-looking bugs that you and colleagues at Washington State have tracked, but our numbers are much, much smaller, I think, than our colleagues in other parts of the country. Why is that? Yeah.
So I don't have the answer to that question. So we, Alaska and Hawaii, I think have the lowest antibiotic prescribing in the United States. And we in the Pacific Northwest, and I think Alaska as well, has pretty low antibiotic resistance relative to other parts of the United States. Antibiotic resistance does reflect that map that Scott showed, with higher prescribing being matched by higher antibiotic resistance. Interestingly, LA County has a lot of antibiotic resistance, so it doesn't hold true across the western part of the United States. And I don't really know what the answer is about that.
Doug, how do we do you happen to know how we compare, for example, to agricultural consumption on a per animal basis with other states in the nation? Is there such data?
There isn't such, that data does not exist. However, we do have a fairly low density of livestock and poultry in the state. We do have a fairly large dairy industry, but honestly it's quite small relative to other states. So it's partly a numbers game again with people. We actually have a pretty small population in Seattle. It may look big, but I was just in Shanghai and I think it's a neighborhood. We actually have a pretty small number of people in the amount of space that we have.
Thank you.
Yeah.
While we're waiting for someone to,
Can you guys just hold the mic closer just to make sure that people can hear on the live stream? Okay, any questions? Okay, great. I'm going to toss this to you, so you got to be ready to catch it.
well played.
Top right here. Okay, thank you. I'm a food animal veterinarian, and more comments than questions, I guess. So I would like to first say this is a great discussion. I think it should be at all levels, whether it's producers or community meetings or anything like that. It's an excellent discussion. From my viewpoint as a veterinarian working out in the mud and the muck every day, this is at the top of my list all the time. And talking to my colleagues, it's on their list too. And all of the associations, it's in their one of their top 2 or 3 priorities as far as what do we need to do to make this a better industry, whether it's swine or poultry or dairy or beef. I think what we're doing too is to mitigate a lot of this is we are pushing for better animal husbandry, whether it's Purdue is able to do their no antibiotics ever, a large part because they put fewer birds in their houses. There's other things that they did as well, but that was one thing. More space for pigs, more space for the dairy cows. So that's a huge part, plus also emphasizing vaccination programs and protocols rather than relying on an antibiotic to fix the problem. Unfortunately, we also have a lot of momentum behind this problem. This is the way we've done it, Doc, for 40 years. Why should we change? And so there is that issue to face. But we are working on it. I just wanted to reiterate that the veterinary field is working with producers on it. And a lot of the sharp producers are definitely on the forefront of saying, okay, we have to change. We got to do something different. Because 1, it's too expensive to treat with antibiotics. 2, we have better production if we can get by without antibiotics and manage our animals in a different manner. One point of clarification on the 30 million pounds of antibiotics that were used, 12 million of those were not medically important, just to make that point. Other than that, we still have a long ways to go. Thank you.
Thank you so much. Thank you.
Anyone else have a question? I know I saw some hands up. Okay. You ready? It's okay. You can catch it.
Okay. I'm a high school teacher, biology and biotechnology teacher, and I guess this is both to you and to the gentleman from WSU. What's being done as far as outreach to Future Farmers of America, Boy Scouts of America, Girl Scouts of America? Because I'm a firm believer that the youth are really, it's not your farmers, it's your next year's farmers that are the people that have to figure this out.
Yeah, I don't know on the K-12 side. I do know that in my own experience, in a very good school system, you're not seeing it. But from the Extension Service perspective from Washington State University, people like Dale Moore and Bill Sisko and so forth are really working hard with the dairy industry to understand their prescribing practices, why they're making the decisions they're making, and to affect changes in those behaviors, because it really is a behavior issue in those circumstances. We are absent on the K-12 side, I think. That's just my impression, and that's part of the reason I pointed out food safety is not emphasized or taught. We're not taught how to protect ourselves from those rare occasions when the risk is real.
Could I ask you a question also while the
Yes.
mic makes its way over there?
Sure.
The difference in terms of impact in a scenario in which you have antibiotics that you would consider using for the prevention of the spread of infection compared with waiting for an infection to happen and giving one animal a lot of antibiotics. How do you make that calculus? If you think you may be on the verge of a nascent outbreak and trying to decide, should we give antibiotics on a preventive basis, not for growth promotion, but to prevent the spread of an infection within a community of animals?
Thank you very much for the question. And this is really where one of the next big controversies is going to be, much as it was in Denmark, is the question of preventative use of antibiotics. Because if you're giving long-term exposure to high levels of antibiotics, and I know people like to say it's not high, but about 100 parts per million can make a big difference in selection, even in the GI tract of these animals. But there are very creative or very strategic ways that we can use antibiotics in a preventative fashion when we know there are key points in a production process where animals are going to undergo stress, And the use of an antibiotic at that one point in time can actually prevent the need to use much more important antibiotics downstream. And just as an example is shipping fever with cattle. If you actually bring animals into a feedlot and you hit them with a 4-day dose of chlorotetracycline, you actually will dramatically reduce the need for much more important macrolides, florfenicol and ceftiofur to treat respiratory disease in these animals, and you're not going to have any impact on that GI flora. At least that's what the data suggests right now. So that's a strategic application to prevent disease, which actually helps in the long run in the fight against antimicrobial resistance. The long-term exposure needs much more scrutiny in those situations where that's happening.
Thank you. Here's a question here, please.
Hi, yes. I'm a nurse practitioner and I work in urgent care. Almost every day I get reports, my patient satisfaction reports. You can see where this is going. And I talk till I'm blue in the face, and I probably am one of the lower antibiotic prescribers where I work, but ultimately that's there. Fortunately, my compensation is not tied to this, and reducing inappropriate antibiotic use is a goal, but it's there, and people can hop to a different, if they're not happy with what they got from me, they can hop to somewhere else. And also we lack appropriate, really specific measurements for, upper respiratory infections. We can't test for most things, and so it is a little bit of a gamble, and a little bit of a, litigation is a concern and things like that. So what is the answer for that? I understand that feed use of antibiotics is probably a bigger concern overall than human use, but that is also important.
I'm not sure about the answer to your last question, frankly. I think that is controversial. We should talk about.
That's right. No finger pointing.
But Dr. Weissman, can you reply with a special eye towards new science in the psychology of how we should talk with our patients? There is new data.
It's a fantastic question. I think that's really where the rubber meets the road. So I think it's going to take many things, many types of intervention, including retraining or training the next generation of prescribers, as well as educating patient populations, and that can happen through larger campaigns. It can happen at the clinic or the hospital level with providers putting posters up with their picture saying, I am, Marcus Welby, MD, and I don't prescribe antibiotics unless you're really, we really need them. And that kind of accountability has been shown to be the kind of behavioral nudge that has come out of this behavioral economics field. But I think the story or the anecdote that I like the best in all this, the model of stewardship as kind of a, if you're familiar with the story of the sirens, Odysseus is making this wonderful journey, and he's on a ship with his shipmates, and they're passing through the place where the sirens out in the water are singing this beautiful song that lures sailors off their boats or lures ships off course to destruction and death on the rocks. But Odysseus, the hero, wants to hear this beautiful song, so he insists that all the shipmates plug their ears while he himself is lashed to the mast, so that he may hear that song without heeding the call and being destroyed on the rocks. And I think that good stewardship, which consists of, financial incentives, financial disincentives, making the system work just like right now. Maybe patient experience surveys are an incentive to prescribe structurally. Maybe there are other quality incentives, and many healthcare networks are starting to think about maybe bonuses come from measured metrics around appropriate antibiotic prescribing, about using more narrow rather than more broad antibiotics for a given infection, not using antibiotics for certain upper respiratory tract infections and viral infections and so forth. But there are many pretty notions about stewardship, and one of the slippery things that we know about our own minds is that we can recognize that resistance is a problem out there. It is definitely a problem, and probably my buddy is probably part of the problem, but I'm pretty good. I'm not part of the problem. I know, and this kind of touchy, this happy notion that everybody can be a steward. I mean, it's the fox guarding the hen house. So I think. We're just now on the cusp of trying to leverage the fact that These behaviors are entrenched. We're trained to do this, and yes, people are going to go to other prescribers, so why don't we just get this done for this family? We're in this for the long haul.
I want to do something a little unusual. Would you give that cube to the doctor behind you? You'll see her in a blue sweater. That's Dr. Chloe Bryson-Kahn. Chloe works with Dr. John Lynch, who's here as our Director of Stewardship at Harborview. Chloe's one of our ID fellows. Many in the room are healthcare providers, so I wanted to hear from someone who's just beginning her career in stewardship. Sorry to put you on the spot.
That's okay.
Would you be kind enough to quickly summarize the work of Dr. Julie Simzak regarding the way that we should talk, especially to patients in pediatrics, coaching on language to answer her question?
So it's actually not Julie Simzak, but it's work coming out of the Children's Hospital in Seattle that I like to talk about often, which is work that they've done in the outpatient center looking at provider language and also provider and patient perception of what is going on in those interactions in the room. And sort of unsurprisingly for us, providers overestimate what patients are asking. So patients will come into the room, and the language that patients and families use to describe how they're sick, we interpret as they're demanding antibiotics from us. We must give them. That is not always the case. I think the other really interesting thing is that there is some particular language that they've detected in these interactions, which not only helps providers talk to their patients better, but also out of the office feeling more satisfied than if the provider had just given the antibiotic. So maybe Dr. Weissman can help me, but I think the language that they found is sort of the sandwich where essentially I think that they say 4 steps is how it works. So number 1, you examine the patient, and as you're doing so, you describe what you find. So I see a very red throat, but nothing white that looks like bacteria, so this seems viral. You have a nasty runny nose and a very bad cold. So sort of tell them what they have, and then you do this language ninja work where you say, what you want to say is something that tells them that you are not done so that they don't interrupt you, but you say, on the one hand, I don't think you have a bacterial infection, so I won't be prescribing you an antibiotic. On the other hand, so they don't jump in and interrupt you then. On the other hand, here's what I want you to do. Go home, take Sudafed, stand in the shower when the shower's running so you feel better, and in 2 days, if you're not feeling better, call me. I'm here. Here's the thing I want you to look out for. And if providers, so the providers that they've seen do this, I think they've listened to 200 hours of tape in the office, the patients are much more satisfied than if we'd just given the antibiotic and sent them home. So.
Would you like to come down here and take this seat?
I told you she was
so
great.
I think there are absolutely strategies, and we're only beginning to uncover what actually works. But prescribing antibiotics might not always be the answer.
To Peter, thanks.
So just one other thing that, if sort of on a research side that may turn into practice and maybe some hope, is that I think just like the poultry industry, I think a lot of us feel in medicine that there really aren't that many downsides of giving antibiotics to one person, and there could be an upside, it might help them, but it really isn't going to be that bad if they take it, maybe on a large global scale. But I think what microbiome research is starting to show is how incredibly important our gut microbiome is, and even one course of antibiotics is going to shift that microbiome for months at a time sometimes before it gets back to where it was. And I think if we start realizing how important our microbiome is for our own metabolism and immunity and things, and if we're taking a drug which is going to screw it up for 6 months, we might start thinking differently about taking it ourselves. And I think, as I understand it, the agriculture industry, as they try to use less antibiotics, is actually trying to feed animals differently and things and try to encourage healthier microbiomes so they don't need as many antibiotics. And we may start following that at some point if we can understand the microbiome better. I would put in a plug, too, for the microbiome research going on here at Fred Hutch and other places at UW. And maybe we'll know someday.
Questions from the room? A couple over here, Steve. Maybe
you're going to have to catch this.
Dr. Holmes will catch the microphone. And he did.
Talk on the black side.
The black side, okay. There's the black side, okay, good. Well, this is, for me, sort of like deja vu, but in the opposite direction.
Would you please introduce yourself for those who don't know you,
King
sir?
Holmes is my name. And I started my medical training at Vanderbilt in 1967, and the head of infectious diseases saw my interest beginning to percolate along in infectious. He says, "Don't go into infectious disease. Whatever you do, I mean, they're all becoming resistant." but furthermore, there are so many new antibiotics coming along, you know, that we're just not going to have any problems that you have to worry about. So look how this has changed, and I think this has been a wonderful program. You've really put together something that's pretty exciting. And I also wanted to point out that you haven't mentioned yet that the U.S., the American Academy of Medicine has just come out with its new recommendations for what should be the highest priority for the United States in global health. And number one, they listed 14 of the top priorities, and number one was non-communicable diseases, but number two was antimicrobial resistance. And we really need more resources. This is a global analysis that they've made, and really it's getting worse everywhere.
Doug, do you want to comment on some of the work that you guys have done? You're working a lot internationally.
Can you tell us more about your work overseas, in Africa especially?
Well, sure, I can tell you briefly. So we did some work, a large study in northern Tanzania, which again is a much lower density populations, looking at the question of how antibiotics are being used in livestock, amongst particularly Maasai pastoralists. The livestock in these communities is really their home equity. That's where the value of their economic value and household welfare comes from. And in that area, oxytetracycline is the elixir of life. They are very good at recognizing what needs to be treated, or what disease states are, at least for their animals, not so much for themselves. And they do use quite a bit of oxytetracycline. The good news I can tell you is we find absolutely no signature of impact back on to people in those circumstances, but within Maasai households, the primary risk factors for carriage of antibiotic-resistant bugs like E. coli is actually the consumption and handling of milk. Milk is a major fantastic source of protein and nutrients, critical to proper nutrition, particularly for children. And unfortunately, ironically, it's also a major source of disease transmission and transmission of antibiotic-resistant bacteria. So that's actually led to a program we're trying to get funded for doing intervention in pasteurization. Maasai do not want to boil their milk. It's culturally repulsive to them. But if you can get them to heat up 70 degrees, hold it for about 30 seconds or so forth, most of the problem is going to disappear, as long as it isn't then poured back into a dirty container and sitting there for 2 hours, in which case they get massive replication of antimicrobial resistant bacteria. The problem of dealing with drug residues in this particular case, we can't even get to that problem yet, because these people are on the economic margin. They're not throwing milk away because they can't afford to. It's too important to either sell or consume at the household level. But if we can at least start getting to the point where we have less disease transmission, less bacterial transmission, we could actually make an impact, positive impact, at the household level, which translates down the road to more kids getting education, more kids contributing in those societies, which everybody wins from. In places like Kibera, which is one of the largest slums in Africa, I mean, we're talking 77,000 people per square kilometer. Whitman County, where I live, is 323 people per square kilometer. I mean, it's dramatic. Very dismal place for a number of reasons. And antibiotic use is rampant. People can get whatever they want, although they typically are using mostly amoxicillin. Number one identified drug in these households. Surprisingly, not much tetracycline in my book anyway. In Guatemala, we see a lot more tetracycline use. And again, things that people can buy right at the pharmacy or the chemist shop. But at the same time, we don't see a signature from that antibiotic use, in part because the whole place is so flooded with antibiotic-resistant E. coli. Primarily in your traditional drug categories, your beta-lactam at the ampicillin, amoxicillin level to tetracycline, strepsulfa, and trimethoprim resistance. Much less we're seeing in the higher level antibiotic resistance categories. But it can grow there. And in some respects, that also brings up the question of the carbapenem-resistant E. coli, which we're starting to study now in 2 hospitals in Nairobi with CDC's funding. We don't use carbapenems in livestock treatment, at least not on any kind of routine basis. So there isn't a selection force in livestock. However, carbapenem resistance conveys resistance to third-generation cephalosporins, which we do use in food animal husbandry, not on a, but only for treating overt disease. That has been clarified in the rules in 2012 from the FDA. But that can technically select for carbapenem resistance if these bugs get into our food system. So biosecurity, not only with people in Africa, in terms of protecting them from hygiene problems and sanitation problems, but here we actually need to protect our farms from us because we're the source of these agents that can then get established in these farms. So, kind of
That's superb. Thank you very much. I think we had one question from Brian Worth, please.
Yeah, Brian Worth, UW School of Pharmacy, and I'm interested to hear some thoughts on how we create consumer demand for antibiotic-free meats and livestock, especially when, you know, at hospitals and universities, it's even challenging to get your own cafeterias to source responsibly. So, Paul, I think you maybe were involved with the effort at UWMC, so maybe you could even speak to this some.
And I'm so glad you reminded me of that. For those who don't know, Frank Perdue Jr., PhD in biology from UW, go Dogs. So that's one of the reasons why we were able at my hospital to bring a largely antibiotic-free meat source to that hospital. And at the Hutch, the same is happening here. Thank you so much. That's an open, I have my opinion, but you don't want to hear from me. That's an open question for everybody here. Peter, what's your thought?
So I think, you know, we all need to learn more about where our food comes from, and I think we need to advocate for better types of food, and I think we need to do it in a smart way. I think I think there's a lot of labeling issues that rely on consumers not being very well informed. So antibiotic-free doesn't always mean they've never used antibiotics. It may mean that there's no antibiotic residues in the meat, which is already regulated already, so it really means nothing. So you have to have labels that actually correspond to something that you understand what it is. And I think the same is true of organic. As I said, I've seen organic farms where they're treating animals with life-threatening infections with garlic and IV fluids because they don't want to waste that cow from their organic line, but the cow is not getting great animal welfare treatment. So I think we are so cut off from our food production that we need to engage, and I think we need to push for the least use of antibiotics everywhere and on farms through food, but we need to not get we have to be careful with labels, and antibiotic-free may not be the right name for it. We have to make sure what we think it is actually what it is.
Thank you. Maryn, please.
Oh, I just wanted to jump in on the consumer demand issue. Thank you for your tweets, by the way. That's you, right?
Yeah.
So I think the good news here is I think that consumers are already waiting for this. And consumers are actually out in front of producers. The reason that Purdue, led by Jim Purdue, graduate of UW,
Jim Purdue,
made their change to change their production over to antibiotic-free is not particularly because they wanted to stop contributing to the burden of antibiotic resistance in the world. It's because they were getting 3,000 comments a month from their consumers through Facebook and email and social media and so forth, asking when their buyers could have antibiotic-free meat. And I really believe that I couldn't give you hard data. This is a journalist being qualitative again, sorry about that. That both the reason why the Obama administration felt that it was time to reopen the FDA rules and why so many, particularly poultry companies, have turned over toward antibiotic-free production is because they knew there was a market waiting, that they wouldn't have to go out in front of consumers and convince them. Consumers were waiting for them to do it. And now there's, now there's pressure on pork and cattle to follow. Those, as these faculty will know much better than me, pork and cattle are harder animals to do. They live longer, they move around more during their lives, they have more pathogen exposure. Chickens are kind of simple, and fortunately chickens went first.
We have time for a brief comment from Dr. Weissman.
So, I think hospitals have a very interesting role to play in this, and it comes down to walking the walk. And University of Washington showed us how to do this. and we followed suit at Seattle Children's, and it seemed like it was such an easy case to make, although there's the long delay of like finding the suppliers. That is a challenge, but it starts with asking the question. It starts with saying, all right, so far of our total, purchasing, we're at 0% antibiotic free. That's a little lower than we want, but so because it worked so well here, if we can't do this here in Seattle, so I think it starts with the bastions and making the case here and seeing that it can spread. And so we have a group called the Clinicians for Comprehensive Antibiotic Stewardship who are studying how to do this, how to write the letters within their organizations and how to make the case to their food and nutrition services about doing this and making this sort of a wave, sort of an industry standard. And I think that antimicrobial stewards in particular can kind of lead the way as kind of insiders who can leverage the purchasing power of medical centers.
Let me follow on that topic. We're almost done with the formal seated portion of the activities. After this, we will all go, I hope, and have something to eat and drink together and have more of a conversation.
We're between you and wine, so we'll try to make this quick.
Alcohol will be there. But in that same vein, I want to get back to that first question that was asked over here around education. And the question, I'll start with Dr. Liu initially. The question is simple. What would you, we have many students in the audience today. What advice do you give to people who are now, if not angry, at least inspired? What would you tell someone who's interested in a career in this field? What should they do next?
So great question. I think that there's a lot of potential ways to get involved. I think, first of all, there's been a lot of attention, I think, in medical education. Paul's been actively involved in this and really just trying to make sure that those medical students, graduate students are actually getting a curriculum and getting opportunities to learn more about antimicrobial resistance and stewardship early on in their training, because I think that that's where we really do need to begin. We need to start early. Oftentimes, by the time people are prescribers, they're out in the wards and prescribing, you're sort of it's a little bit too late at that point, because I think people very quickly have adopted prescribing behavior. So you really need to start early, and so I think building the medical school curriculum, building the public health curriculum so that antimicrobial resistance and stewardship concepts are taught early on, I think are very important. The IDSA, the Infectious Disease Society of America, as well as other organizations have opportunities where students, trainees can actually participate in mentorship activities and go to meetings where they can learn more about antimicrobial resistance and stewardship, where they can be paired up with mentors and learn about career opportunities and ways that they can contribute. There's many different pathways, as you can see from the audience, from the panel members, ranging from public health to clinicians. And so I think there's a number of different opportunities. I think that we need to work on making those opportunities available as well, and I think a lot of work has been already happening in that arena.
This is very helpful. And Dr. Dongley, for those who may not go down a clinical medical training pathway, but who are interested in public health and epidemiology, what would you say to people who are interested in a career and they want your job? What should they do to get it?
Come get it, right?
Prepared to answer that question.
That's why it's a good question.
Well, what I did want to say, though, is I think there needs to be a lot more awareness of what everything means. And I'm an epidemiologist, so I think words are really important. And the point you made about antibiotic-free, that actually all meat is antibiotic-free. It should be antibiotic-free. And so I think, first of all, we need to understand how the antibiotics are used, to have more transparency and better labeling. And I'm sorry, I just lost my train of thought.
Careers.
Well,
do you have a summer job for any of them waiting at State Department?
We do take MPH students.
You heard it from her. She's the boss. So we'll be, if you do have interest in learning more about this potential field of interest, I hope you'll buy her a glass of white wine in a plastic cup and talk a little bit about this. because those opportunities are there for you, and I think that's terrific. And we're so lucky in Washington State. You folks may not know this because this is where you live. That tight binding between public health and academic medicine that we have in this state is relatively unusual. We're very lucky, and you see that here with the panelists who've come to meet with you today. So anyway, I would encourage you to capitalize on that and talk with all of these wonderful panelists. I think it's appropriate for me to say we're at half past, and it's been a heck of a ride. We are so grateful to our keynote speaker and to all of our panelists, and we hope everyone will stay and keep this conversation going.
And I just want to personally thank everybody again who helped put this together. It was a great team. I'll point out again,
what a great crowd that was here. We had a high school teacher. We have one of the cheesemakers from Beechers. So if you're available afterwards, I'm happy to taste anything. We have a lot of MPH and graduate students, which I think is really fantastic. Medical writers that are here. Even some of our students that have backyard chickens, in their notes they put this and told us about that, so that's really awesome. So it's great to hear that people are learning that way. I encourage all of you, there will be time to speak individually to these folks. They're really experts in their fields, and that's why we have them here. They're much smarter than I. So please track them down to ask questions about this. But again, I want to thank you all for coming, and please thank the members of the panel and to Maryn for really setting us down this pathway.